Hello everyone and welcome to this AFAO forum on monkeypox. My name is Heath Paynter. I'm coming to you this morning from Gadigal country, the lands of the people of the Eora Nation. And I want to acknowledge and honour elders past, present and emerging. And this is a national audience, so can I acknowledge all the lands that, that you as participants are joining us from throughout New South Wales and across Australia. This is a really important forum that we've decided to host at really short notice. As many of you know, we are starting to see an escalation of monkeypox virus cases across the Northern Hemisphere, so across Western Europe, North America and in Australia. B&O News are reporting close to 1,000 cases of monkeypox virus in the Northern Hemisphere, including here in Australia, with about 250 in the UK. And in a city, Montreal, the Canadian city, which is similar in size to Melbourne and Sydney, we've seen about 60 cases, most of which are community cases of community transmission. Here in Australia, we have 6 current cases. One of those is a case of community transmission. The other 5 are overseas acquired and were detected shortly after the individuals returned to Australia. I want to make just a couple of short points before we step into this webinar. This forum will focus on the outbreak in the Northern Hemisphere and not the endemic outbreaks in Africa. And we've made that important distinction because we want to focus on the challenge before us. During this forum, you'll hear a lot of we understand from what we're hearing, it seems. And I want to make this clear at the outset that this is a challenging situation with a lot of unknowns, and it's very different to the forums we have on HIV, where we hear a lot of the evidence shows, we can say with a lot of certainty. At the moment, it's largely that the evidence and the knowledge we have is largely through individual case summaries and clinical anecdotes. And so you will hear a lot of speculative talk, and we hope that over time that will change as more evidence comes to hand. One other point before we get going, if and when cases of community transmission do start to occur again in Australia and even escalate, and we think that that will happen, it's inevitable that media commentators across Australia will start to discuss perceived and real behaviours that gay and bisexual men engage in, and even more so that media commentators will start talking about the symptoms that are very obvious with this outbreak of monkeypox. And what I mean by that is there's going to be discussion of genital rashes, rashes around the anal and penile region. And this will become quite a challenging period of time for our communities. And I want to say that this is the first, but by no means the last community sector forum that AFAO will do as we work with our members and with our stakeholders to build your knowledge so that you can work with our communities, because I think our communities across the next little while will need our members and our community organisations more than ever as we work through this challenging period. We've got a great panel of experts who we brought together to help us work through our understanding of monkeypox. Joining me on Gadigal country is Matt Vaughan from ACON, and I'll engage Matt later in the forum on a discussion around communications and risk communications. Down on Naarm in Wurundjeri country, Edwina Wright, who is well known to our sector. Edwina works at the Alfred Health as an HIV physician. And Allen Cheng, Professor Allen Cheng, and it's great to have Allen with us. Allen is a former Deputy Chief Health Officer in Victoria, former co-chair of the Australian Technical Advisory Group on Immunisations, ATAGI, which is a group we've heard a lot of in the last couple of years, and currently has formal roles at the Therapeutic Goods Administration, the formal committee roles at the TGA. The way we're going to structure this is we're going to have a discussion on the clinical profile of monkeypox virus, and then we'll step into a bit of a bigger public health discussion by looking at the communications. So I want to start by going straight to Allen and Edwina and have start the discussion by talking about case recognition. And perhaps if I can ask the question of both Allen and Edwina, can you tell us what we know about the typical symptoms for monkeypox virus infections so far?
I might start off if you like, Edwina. Thanks for the opportunity to come and speak to you all. And I would really like to start by saying what a terrible disease, what a terrible name that's been given to this disease, which I'm sure is not going to help anything. Where everyone is sort of very conscious of all the other issues that relate to people who are affected and risk populations, but having a name like monkeypox actually doesn't help much. But there's probably not a lot we can do about that, unfortunately, at this stage. So just in terms of the typical symptoms, so the textbook sort of description is that, and bearing in mind that not a lot of us have actually seen a lot of cases, this is what we read what we do from the textbooks, but the textbook description is that it starts with a very non-specific syndrome. So it's like a flu-like illness with fever and headache and aching joints and fatigue, and part of that can be swollen lymph nodes, which are sort of the lumps under the arm or at the top of the leg or around the neck as sort of early signs. And that's obviously very non-specific. You can't tell what illness it is going to be from that. And then after a few days, you get this lumpy rash, and it's described initially they're sort of fluid-filled, and then they become pus-filled. They classically start around the mouth and the face and then spread out to the limbs. And so when it's sort of in its full stage, it's actually, there's more lumps around the limbs than there are around the trunk. And that's sort of one of the characteristics that would separate it from a disease that we're probably a lot more familiar with, like chickenpox. So having said that, that's the textbook definition or description of this illness. There's a lot of reports of what we call atypical presentations. So these are things that don't follow the textbook. And one of the things that we are learning is that sometimes there isn't a fever, or sometimes the rash might occur before the fever. And there seems to be a lot more reports, particularly recently, about rashes around the genital region or around the anal region. So this has actually probably always happened, but hasn't been well described in the past. The other issue about this is that it can look like a lot of other diseases, particularly early, and particularly obviously that we don't have a lot of experience with seeing these. So chickenpox is probably the one that it looks most like. Yes, it can look at sometimes a little bit like measles or herpes and other sexually transmitted diseases, but in general, this is a distinct infection, and it does look different from other diseases. But sometimes it takes an expert to be able to tell the difference.
And is there any evidence or anecdote of asymptomatic infection and the possibility that the virus has been circulating in the Northern Hemisphere for longer than the last month?
Yeah, so people talk about what's called subclinical infection, and that's meaning that it sort of flies under the radar. But it can mean, subclinical can mean a couple of different things. It can mean that people truly don't get any symptoms at all, or they get a lesion where they can't see it or don't know that it's there, or they don't get sick enough that they will go and need to go and get a diagnosis. Or maybe it's just a very mild rash, and people say, well, it's just something, I cut myself or I hurt myself, and it's not sufficient for the person to be aware. So they're sort of, are they really don't have any symptoms at all, or do they have, very mild symptoms? We're not entirely sure. It's not clear. We think, sort of classically, we think that people have to be symptomatic to have to be infectious to others, and particularly they have to have a rash to be infectious to others. But we're still learning a lot about this, and there are clearly transmissions going on where we just don't know where they got it from. So is that someone that had a very mild infection, or they didn't know they had infection? Is not entirely clear at this stage.
I think that's interesting, that point around the transmissibility and being symptomatic. Sorry, Edwina, were you?
Oh, not at all. Yeah, I was just going to say a couple of things. When we train as infectious diseases physicians, one of the things we were taught about as registrars was that smallpox versus chickenpox is chickenpox, the lesions develop at different rates. So some are already scabbing and then new ones are emerging. But monkeypox is just like smallpox, meaning that the vesicles are all of the same age. They all look identical. So there's not a staggered presentation of, so that's something for clinicians to look for. And Alan, I think we were talking earlier this morning that there have been other earlier reports of so-called atypical monkeypox, mainly coming out of African countries, meaning that people turned up with lesions without a fever and a chill and a rash for several days, then the rash. And some of the thoughts around that was actually people handling animals that, of course, are the vectors, if you like, of this, the well-known vectors. And so if an animal were to bite you directly or scratch you, then you get an immediate inoculation. And it's thought that that may circumvent the whole incubation. That may mean that you get a quicker presentation of the illness with the rash before the fever and the prodrome, versus just petting an animal or cleaning the cage of an animal that's infected, where you might inhale it and have a slower and a longer incubation period. So it's probably just worth qualifying. We don't think this is the first time that the so-called atypical features have occurred. So again, trying to offset it being a gay male thing or a bisexual male issue. So I think that's important for people to know.
Yeah, that's true. Yeah.
And can I ask, with skin-to-skin transmission, which I think is what we're seeing in the Northern Hemisphere and in Canada and in Australia with the transmission, what's the incubation period for that or do we know what the incubation period is for transmission through skin-to-skin contact?
Yeah, so it generally is between 1 and 2 weeks, so between 7 and 14 days, but there is a range around that. So, obviously it tends to be around 7, but then it can, like with COVID, it can be a bit longer. And there is a range that goes from 5 to 21 days. So, and we use the outer limit sometimes for, things like, quarantine periods or periods that we would watch someone a bit more closely.
Thank you. I just want to move to viral transmission. And the question I have around this is, noting that it's a non-clinical audience, can you explain exactly how transmission occurs through skin-to-skin contact?
So I think in general, and again, this is sort of by analogy to smallpox as well, the virus is in the rash, those fluid-filled blisters and pus-filled blisters, and that's what people catch. So it probably is other ways of transmitting it, but that's probably the main way. And so it has always been known that it is about close contact. So people get it in households, and healthcare workers can get it if they're not using personal protective equipment. And so sexual contact is obviously a subset of skin-to-skin contact. So that's what seems to be the risk factor in general. Having said all of that, hearing all those reports about genital lesions specifically might suggest that there are specific behaviours that are higher risk, but in general, it is still close contact, skin to skin, because of contact with the rash itself.
There's a question that's come in. Are you able to talk about what the actual the lesions or the rashes look like? So there have been some photos that have circulated whereby they actually look quite perhaps benign is not quite the right word, but not that severe. So almost like a pimple. And then there are, of course, these much more severe looking rashes in some of the other photographs. Do you have a sense as to what the rash and lesions might look like?
I would describe it, particularly for public, as very much looking like chickenpox. So it's a lumpy rash. It starts off with fluid-filled blisters and progresses to pus-filled blisters. The distribution is slightly different. The time course is slightly different. So it's not exactly the same disease, but it looks quite similar to that. and there's a staging system. So we say that if there's less than mild disease would be 30 lesions across the body, and then moderate would be between 30 and 60, and if it's over 100, then that we would sort of call that severe. So there's quite a range. So some people can have a relatively few number of spots, and then some people can have quite a lot. And again, that's a little bit like chickenpox. Some people get hit pretty hard with chickenpox, and some people get away with a relatively mild illness.
And there's been talk in the Northern Hemisphere of some people experiencing a lot of pain and actually needing pain medication as they're recovering from infection. Are you able to comment on the degree to which the lesions might cause pain?
So I think those lesions can be painful. They're inflamed. So, and again, probably like any other inflammatory condition, chickenpox and other infections, that can be somewhat painful. What we do see at times, I think in about a third of people, is a bacterial infection gets in on top of the viral infection. So they can get a skin infection that's caused by bacteria on the skin, and that also can be more painful. So it can get complicated and cause problems that way. The other thing that has been reported, and we're not entirely sure how common this is, and obviously there's a lot of factors that might weigh into this, is that people can get quite depressed with it, and we're not sure if that's something that's specific to this virus, or it's just because people have to sit alone and have all the issues related to this infection. So I guess that's something to look out for if you do know people with it, is to reach out to them and make sure that they're well supported through this. That's
a really interesting point, Alan, and I think particularly for the work that our member organisations do around working with our communities, particularly in the space of mental health. So we might come back to that at a later forum as our knowledge of the virus progresses. Just in terms of transmission, we're very familiar with the words droplets and aerosol from the COVID pandemic. I want to ask you about the transmissibility of monkeypox virus through droplets and also through aerosol. And I guess the context of this is, if people are in a bar or in a cafe and someone has monkeypox virus, how at risk are they in those environments of acquiring the virus?
So we're not entirely sure. We think that it's the predominant mode is still skin to skin contact. So where I've heard stories of people that have had contact with people in a bar, but then where they've had their lesion is on the cheek. So would suggest that it's the contact that they've had rather than just sort of floating through the air and catching it that way. Having said that, we do know that smallpox was known to be spread by droplets and aerosol and other what we call fomites, which are sort of like blankets. If some of those viral particles get on blankets, it's able to be transmitted that way. So particularly in hospitals, we take a lot of care in where people are going to be placed and put them in by themselves in to stop spread to other patients. But we think that close contact and skin-to-skin transmission is still probably the most important way of transmitting it. We can't say that it isn't transmitted by other ways, but we think that probably is less likely and far less dangerous that way.
And if we see an escalation of cases in Australia, people get the virus, people recover, what do we know about reinfection?
We don't know at this stage, but smallpox was certainly a disease that you didn't get twice, and vaccination was very effective against it as well. With monkeypox, we also think that if you get it once, you won't get it again, but we don't know that for sure at this stage.
And I just want to move to a subject area that's very close to our sector, and that is monkeypox virus and HIV. And the question. Two questions. Are people with HIV at more risk of monkeypox virus infection? And if someone with HIV were to acquire monkeypox infection, what would that look like in the context of co-infection?
So what we do know is that people with a weakened immune systems can have severe monkeypox. I'm not so sure that having HIV or having a weakened immune system is a risk factor for getting it. But if they do get it, then it can progress to severe disease. But HIV obviously is now very treatable, and most people with HIV who are on treatment have, essentially normal immune systems. So in that context, we're not so sure that that whether that's a risk factor for severe monkeypox. What we do know, at least from the first 300 cases in the EU, and I would assume, but don't actually know what proportion of those had HIV, is that very few of them have required hospitalization. So I think 2 of the 300 or so in the EU have been hospitalized, and of those, 1 is an infant. So the other risk factors for severe disease are very young children, so infants, pregnant people, and then immunocompromised people. So the degree to which HIV is a risk factor is not clear. It's likely that people that are on treatment and have well-controlled HIV probably aren't at a huge risk of severe monkeypox, but people that perhaps don't know they have HIV or aren't on treatment may be at a higher risk of severe monkeypox infection.
And Edwina, I just wanted to, sorry, I was just going to throw you your expertise in HIV if there was anything else you wanted to add.
Yeah, thanks. There are a few papers on it. The best one that I've been able to find was actually from last year in Clinical Infectious Diseases, and it was coming from Nigeria. And of the 40 people whom they reviewed with monkeypox, 9 were living with 9 had HIV, were found to be HIV positive. And of those 9, 4 were newly diagnosed, and the other 5 were previously untreated but weren't at the time. So this, first of all, brings up an issue which we can discuss perhaps later, which is we might begin to find that in Australia potentially we'll diagnose monkeypox, then we'll diagnose HIV. So we need to look for that as a sequential issue. So they may become potentially closely linked. But in this study of these, and it's a very small study of 40 people, but when they compare the HIV negative cases to the people who were HIV positive, and most of those had low T cell counts. 1 had a T cell count of 300, the others were 20 and 55, and that's all that were measured of the 9 patients. But with those small numbers, they showed that they had a greater likelihood of secondary bacterial skin infections, a longer duration of illness, genital ulcers, and perhaps bigger pustules. So we are now talking about probably very substantially immunocompromised people not on antiretroviral treatment. So that's different from what Alan was alluding to, where we have, a vast proportion of Australians are on treatment if they're living with HIV and successfully virologically suppressed.
And I think that throws an interesting point up in relation to the connection between monkeypox virus and STIs in general. And if someone's died, again, we're starting to move into clinical guidelines. I don't want to get too lost in this, but I think there's a point around people being tested for monkeypox virus, perhaps returning a positive result, and then what should the response be in terms of monitoring those individuals for other STIs, so we don't miss out on a potential HIV or syphilis infection?
Might leave that to Edwina.
Well, no, of course, your guidance is really invaluable, but I think what's probably going to happen, or what is being suggested, is that people coming forward in countries outside of Africa are coming as outpatients and into sexual health clinics and GP practices with what looks like a sexually genitally based lesions. So it automatically invites an opportunity to think about STIs. And I don't think we should miss opportunities for STI testing, and that includes HIV testing. So it might be challenging to diagnose a person with monkeypox and in the same breath say, perhaps we should run concurrent tests looking for other infections. But there's a lot of wisdom in that approach, and I think I would endorse it. This is not to say that we're confident that this is a sexually transmitted infection in the technical sense of the word. And the technical sense of the word is that the virus is in vaginal secretions or seminal fluid and ejaculate, and that's the way it gets into the body. Alan, from what I understand, that has not yet been proven. But if as Alan said, sex is is one of the subsets of close contact. So you acquire it through sex. So that means you've had sex. Let's look for other things via which other viruses and infections that take the opportunity of sex to infect another individual.
Thank you. We might move on to diagnostics and testing. And of course, we're all very familiar with testing from COVID. Alan, are you able to take us through how a test is conducted for monkeypox virus?
Yeah, it's relatively straightforward. So swabs are taken of the rash itself. Sometimes that involves, trying to break into one of the blisters to get the fluid, because that's where the virus is. And then also a nose throat swab, as we're obviously all familiar from COVID. We can detect. Obviously, it's run on a different test, but it is this can be found in the nose and throat as well. It isn't, so they're basically the swabs that we take. It's run on a PCR, which is the same sort of principle as a COVID test, but with looking for a different virus. And at the moment, there's not a lot of capacity to, it's not like a COVID test where every second lab can do it. This is relatively specialized to be able to handle these specimens. So those tests are run in the state reference labs around the country. There are probably some other specimens that can be taken, so blood and urine, but in general, the rash itself is sort of, I guess, where the money is. So that's the primary swab that we take. So I guess there's a couple of special situations. So one is if someone, particularly if a close contact of a case says that they're feeling unwell, but they don't have any rash yet. Obviously, we would look pretty closely carefully to see if they might have a rash, but that might be a situation where just the nose throat swab might be useful. And then generally, you're able to detect the virus until the lesions have crusted over. So sometimes if people present quite late and most of the lesions have crusted, you can generally sometimes get the crust itself and detect it in that. But sort of how long you can detect that for isn't completely clear.
Can I ask a question about window period? This is an audience that knows a lot about window periods with testing. Is there a window period for someone who feels they might have been exposed to the virus and wants to get a test to see if they actually have the virus?
Probably not before they have any symptoms at all. So if they have a fever, then we'll probably take a nose throat swab. But before they get symptoms, I would be confident that any test could rule it out, because it wouldn't say that, a test is always a snapshot in time. It doesn't mean that you might go on to get symptoms down the track.
We just had a question come in which touches on some commentary out of Europe, and the question relates to the possibility of permanent scarring from infection. Are you able to comment on whether there's a risk of permanent scarring from monkeypox virus infection?
To tell the truth, I actually don't know. I don't know if Edwina, you come across any literature on that. I assume so. With smallpox, there was, but
yeah, I think I hesitate to say that. I'd rather get back and check, but I think I've seen photos of scarring from monkeypox on face, but we should clarify that because that's important for long-term, for many reasons in terms of stigma and just cosmetics.
Yeah, I think that's something we can come back to as the knowledge builds. Can we move to treatment? Again, there's a lot of talk about treatment for people with this virus in the Northern Hemisphere. What treatments are available and how do they work?
So there are a couple of treatments that have been proposed and probably, and we don't know completely how much they work. And I think probably the first thing to say is that because monkeypox is a self-limiting, goes away by itself, Most people who don't have severe monkeypox probably don't need treatment. It'll just get better without any specific treatment. That said, there are treatments that have been proposed for people that get severe disease, or people that might have very weakened immune systems, where it might be given early to stop them, to try and prevent severe disease occurring. Or sometimes we would give treatments if it's in a really awkward place, so like the eye would be one where it would be vision threatening, and therefore that you'd get treatment because of that. So the treatments that have been proposed are what's called Technomat. This is an antiviral that interferes with the virus life cycle and stops it replicating. It was originally developed for smallpox, but it does appear to be active against monkeypox, but we don't have a huge amount of experience in its use, and it's not used for anything else, so we just don't know a whole lot about it. It is available in Australia for people, for the hospitals and doctors that need it, but it would be I imagine, in quite limited supply, because it was sort of one of those smallpox preparedness stockpiles. The other treatments that have been proposed is a drug called brincidofovir, and then cidofovir, and people that have experience in HIV medicine, like Edwina, have had experience with using these sorts of drugs because they're used for CMV and for other drugs, for other conditions as well. The data on that is much less encouraging. So there was a case series that was published recently, very small numbers of patients, but people treated with brincidofovir that had monkeypox, their virus seemed to persist for quite a long time after that. So it doesn't seem to be anywhere near as effective as Technomat. So they're the sort of main treatments that are being proposed for monkeypox.
And with Technomat, that's safe to use for people who are using HIV treatment?
We believe so, yeah. There's very little data on its use.
And again, and I suspect you won't be able to answer this question, but again, this is an audience that's very familiar with concepts of PEP and PrEP. Can Technomat be used in either of those for PrEP or PEP? And if it can be used as PEP, do we have a sense of the window period in which one has to start it to ensure effectiveness?
We actually don't know. So it does appear to be, Technomat does appear to be effective in animal studies, but the animal studies the model isn't exactly the same. It's a different virus, they use different viruses, and the incubation period is very different. So, how that relates to the very long incubation period of monkeypox isn't clear. So in general, I think it's thought probably not, that it probably isn't useful as post-exposure prophylaxis, and then there's no data for pre-exposure prophylaxis, so we probably wouldn't give it in that situation.
I want to move to clinical management. So this is the context where someone is diagnosed with the virus. As I understand it, the people who are living with the virus at the moment in Australia have been hospitalised. Is hospitalisation the default setting for someone who is diagnosed with monkeypox virus?
It doesn't need to be. So I think the first cases have been hospitalised partly because we weren't sure what it was, and they appeared to be unwell, and so it was part of making sure that they were cared for, and if it wasn't monkeypox, they would get care for whatever else they might have had. But I think as we're learning more about it, and realizing, particularly like that European experience where, very few people have required hospitalization, I think there's more comfort, particularly from public health units, to allow people to recover at home.
And if people are recovering at home, we have many people in our communities live in share houses. What guidance can we give people living in share houses who might have someone who is recovering from monkeypox virus, or themselves recovering from it, and they've got flatmates?
Yeah, so this is an issue really to discuss with the public health unit. So so if someone was to get monkeypox, they would very quickly get a call from the public health unit to inquire about, their health and their living circumstances and so on. So that would be something to say, look, I would have trouble isolating away from the people that I live with, and they would help out in that sort of situation.
And we've all seen a lot about PPE because of COVID. If people are in hospital, what's the kind of PPE guidance that's given to treating physicians and nurses who are managing someone with monkeypox virus?
Yeah, basically it's the same as COVID. So even though we don't think that the aerosol and droplet spread is the same as COVID, in some ways it's easier for us in hospitals to say, look, we're treating everyone as if they have COVID. So we wear N95 masks and eye protection and gloves and gowns and so on. So it is, I know, fairly confronting for patients to not be able to see faces for long periods of time in hospital. But that's the sort of standard setting that we have in hospitals at the moment.
I want to move to prevention and in particular isolation. And again, isolation and quarantine are things that we're all familiar with because of COVID. There seems to be a bit of a tension in terms of setting isolation periods that are effective and sensible, but not so onerous that they disincentivize affected communities from engaging services for testing and care. Do you have a sense of what a sensible monkeypox virus isolation policy would look like?
Yeah, so this is really the key issue, and we talk about proportionality. So there's a burden that's always going to be put on someone that is isolated or in quarantine. We want to make sure that this doesn't spread. This is an unpleasant disease for the people that get it. We want to make sure that we want to reduce the number of people who get sick. So where is that balance between restricting what people might want to do, weighed up against the sort of the protection of the community? And that's obviously a big issue that's that's played out for COVID. But this is not COVID. This is not smallpox. We're not going to have community-wide shutdowns for this. So just make sure that I draw the distinction between isolation and quarantine. So isolation is, I guess, what we do to people who have the infection to stop transmission. Quarantine is for people who are contacts of people with cases. They don't have the disease, but we sometimes, as you remember for COVID, we would stop people going out because they were contacts to try and prevent chains of transmission going on. So for isolation, so for people that have monkeypox, this is very much a discussion with public health, and this would be the sort of condition, at least at the moment, where you'd get a daily call from the public health unit to find out how you are and make sure that you're at home. People are infectious until the last lesion has crusted, and that can actually, unfortunately, be 2 or 3 weeks. It's a little bit longer than chickenpox. And during that time, the advice is to avoid contact with other people as much as you can. So in a household, trying to stay away from others. They general will let you go outside and walk the dog and those sorts of things, but not to go to work and to avoid contact with other people. Quarantine, so this is for people who are contacts of people, but who are not yet unwell or may not become unwell, generally isn't required for monkeypox, because unlike COVID, people aren't thought to be infectious before a rash or symptoms, but there will be things that will be advised. So during that period, while you're a contact and until you show disease or the incubation has passed and you're confident that you're not going to get an infection, then you'd be advised to avoid sex and other close contact, avoid particularly high-risk people, so infants and pregnant people and immunosuppressed people with compromised immune systems or weakened immune systems. And probably the most important thing is if you become unwell, then you should get tested early. So that's the sort of distinction between isolation and quarantine. So people who have the infection and people who might get the infection, and then trying to be as proportionate as possible to allow people to have some sort of life, but trying to stop this spreading on to other people.
Edwina.
Yeah, I was just going to say, so Alan, could you just kindly walk me through that again? Let's say I'm a woman who's had sexual contact with a person who's, let's say, a man who's now diagnosed with monkeypox. Women do get genital lesions as well. There's been some cases from the UK showing that. I ring my doctor and say, oh, it turns out my partner from a few days ago has now got monkeypox, but I'm absolutely fine. I have no symptoms whatsoever. You would advise me that that I can keep going about my business. I could go to work. I can look after the kids in my house, shop, but I should refrain from intimate contact. And here I'm meaning sexual contact, probably for out to 21 days, which is the upper limit of the incubation period. So refrain from sexual intimacy. What about intimacy, kissing kids or kissing people you love? Because I see that is potentially also a way of transmitting the virus.
Yeah, I think the less contact, probably the better. We don't think that, even though we don't think that you're infectious unless you become unwell or get a rash or have a fever, I guess we're a little bit concerned, and particularly precautionary, where there are parts of the body where you may not be completely confident, like particularly in the mouth or around the genital area, whether there may be some early lesions appearing there. So that's why there's this sort of precautionary, not to have sexual contact. And I probably in that situation would say, you may not want to kiss your kids in this.
Okay.
So that's confident that you don't have it.
So that is okay. And so in parenthesis, it's an impost, certainly if you're looking after a family, perhaps and gay and bisexual men may indeed be doing that. But not kissing my parents and close friends, siblings, just keeping that down. And then you're going to tell me that if I suddenly become very fatigued, if I get muscle aches and perhaps I think I might have a fever, I will call you back, and then then something will be set in motion to have me tested. Is that right? Yeah,
and certainly if you, the advice before you become unwell is if you do become unwell, then you may be infectious. So therefore, really at that point is a good time to, avoid contact with other people, particularly those who, pregnant people, young children, and people with weakened immune systems, to make sure that you might unknowingly pass it on before there's a diagnosis made.
This seems to be a really important part of the next step in where this is going. I don't think there is formal advice on this from health departments at the moment. I might be wrong, but I guess this is one of the next areas that will emerge in terms of providing advice to communities on how to manage being infectious or having the virus.
Yeah, so there's some advice being put together at the moment that I expect should be published sometime this week, and it's very much following sort of what we call a contact matrix. So when people say I've had close contact with someone with monkeypox, there's obviously a degree of a range of risk there. It could be I sat next to someone, or I had sex with someone with monkeypox, and that risk is very different. So what is recommended for someone who's a very high risk contact, so people who've had sex with someone with known monkeypox, for example, those recommendations will be a lot more onerous in a lot of ways than someone who sat next to someone on a plane sort of scenario where there mightn't be so much recommended for them. So that's to come out, and I think that's still in evolution. But the key principle in there is what is being asked of the person, how proportionate that is that to the risk that they might actually get monkeypox.
Could I just ask you, Alan, if I may, because I'm still a bit confused about this. If our exposure is sort of we're talking about skin to skin contact. So I might accidentally, a lesion might break and I'll get it on my skin. How is it inoculated? Do we think it's through mouth, nose, mucous membranes? We subsequently touch ourselves and it gets in through mucous membranes. It's not going to be direct skin inoculation, right?
Yeah, there probably is two ways. So, and then just, again, this is sort of something that we're learning still. I think the classic way is that, yes, it's inhaled and then there's a bloodstream phase and then it comes out into the lesions, and then those lesions, the virus in those lesions goes into someone else's respiratory tract. But I think what we're learning, and maybe more important in this outbreak, is in sexual contact, there's direct inoculation. As you said before, with contact with animals, there's a direct injury to the skin and a breakage in the skin, and therefore those lesions appear at that point, and that may be the same with sexual contact as well.
Oh, I see. So you could actually, even if your skin's not broken, if there's a minor abrasion during sexual intimacy, the virus can go from the lesion of the infected person into that small broken area of skin.
Yeah,
right. Okay.
That's probably conjecture, but that's how I'm interpreting all those sort of reports of genital lesions, and then what you said before about lesions where people have had contact with animals.
Yeah, thank you for clarifying that. I think that's really important for us to try and understand that. Thank you.
I want to move on to communications, but before I do, I just want to quickly touch on vaccines. And again, we're all familiar with vaccines from COVID, but this audience is less familiar with vaccines because we don't have one in the HIV space. But this seems to be quite a complex area. There are issues around the safety profile of the vaccines. I'm going to ask you to quickly respond, Allen, to something that's quite complex. But what if we were to look at vaccines as a way to respond to an outbreak, what would the policy around rolling out vaccines for this virus look like?
Yeah, look, this is a really complicated area, and it is complicated because there are two vaccines. There's the older vaccine, which is second generation of actually the original vaccine from Jenner's time on cowpox and so on. And that vaccine is called ACAM, and then there's a newer vaccine called MVA. The vaccine that we have in Australia at the moment is the ACAM vaccine, but there's work being done to see if we can access some of the newer vaccine. They're very different vaccines, so people older than me will have had that variant of that ACAM vaccine. It's the one where you get a scar in your arm. It's a odd-looking needle with 2 points that sort of like a pinprick, and basically what that is giving someone a very small lesion, and then the immune response from that goes and protects you against smallpox and monkeypox. That virus, that version of the vaccine is, so we talk sometimes about what we call live vaccines and then killed vaccines. That's a very, very live vaccine. It's a living organism, and there are a lot of potential side effects with it. It is something we used to give the whole world, so it is generally fairly safe, and most people won't get major side effects, but some people do get quite serious side effects, and that's in sort of the order of 1 in thousands of people or 1 in billions of people. What that really means is that if we were to give it to a large number of people, we would have to assess those risks and benefits very carefully, and particularly that monkeypox is not smallpox. It's not anywhere near as dangerous as smallpox was. We certainly want to make sure that we're not doing more harm than good by rolling out vaccines. And that applies firstly at the population level. If we give, thousands or people, vaccines, we will expect that we could see side effects, but also occurs at the individual level. So when you talk to someone with that you might be giving this vaccine to, you have to ask about, might they have the HIV, and if they have HIV, what's this, what's the status of their HIV? There are all sorts of precautions and reasons why you may not want to give it because it may be too dangerous. So it becomes a very complicated decision. The other vaccine, the MVA vaccine, is thought to be a lot safer, although, again, we don't have a huge amount of experience with it. And then those risk-benefit discussions would be quite different in that context. So what was used very successfully for smallpox was this strategy called ring vaccination. So that was a strategy where, when there was a case detected, that the contacts around that case would be vaccinated to try and stop spread outside that sort of ring of, it was like a ring of containment. Whether that would work for monkeypox and with the new vaccine is not completely clear, and that's something that's being discussed at the moment. And part of that discussion will be, can we get some of this new vaccine, which is probably going to be safer and can be used in people with HIV and so on. So there's a lot of discussion in that about, what's the best strategy. The vaccines probably can be used in very high risk contacts, but there's a lot of discussion that you have to have with the people involved to make sure that it is actually a benefit to them to get vaccinated.
We might, I think this is an area we're going to come back to if and when the virus develops in Australia and across the Northern Hemisphere. So I suspect we'll revisit that issue progressively across the next little while. I want to move on to communications, and we've probably got about 6 or 7 minutes left. And Matt, I want to bring you in here because this is a really big part of what's happening in the Northern Hemisphere, and I suspect this is going to emerge as we have cases of community transmission down here. There's a prevailing narrative of this outbreak of monkeypox virus, or at least the prevailing narrative seems to be its association with gay and bisexual men. We've heard a lot about parties, and in Belgium and in Gran Canaria, parties that involve sex and public sex between gay and bisexual men. And with this context in mind, and Matt, I'll go to you first and come back to Edwina and Allen for a clinical perspective on this. How can we develop communications that, on the one hand, don't necessarily stigmatise affected communities, but on the other hand, create an environment of safety so affected communities feel comfortable engaging services for care and support?
Yeah, I think this is a really good question, Heath, and it's something that we really do need to be careful with messaging. And when I say we, I mean community organisations, but also governments that are putting out alerts. I think there's a big difference between what a government might put out in a public health alert and then the messaging that we can also do to community. When we have a relationship there with particularly gay and bisexual men and other men who have sex with men, we can say things that are a little bit different because we're talking directly to community. But I think some of the things to make really clear what we've kind of picked up is to talk about the strengths of gay and bisexual men in this instance. So the fact that they have really good health-seeking behaviour, and this is something, particularly when it comes to sexual health, is something to really reinforce, because that creates that enabling environment where it's not blame. It's saying, you've got really good behaviour. This is why we're picking up cases, particularly in sexual health clinics and with GPs. So that's a really thing to get from the get-go. I think another one is also to indicate that, monkeypox isn't just among gay men or bisexual men. It doesn't discriminate based on sexuality, that it actually can be picked up by or transferred to anybody. And that's a really kind of, although a number of cases are amongst gay and bisexual men, is making it clear that it doesn't discriminate is also another clear message to make sure that is regularly put out. Yeah.
Thanks, Matt. I might, Edwina, with your experience in this space, I might get any thoughts from you on that question, but also a follow-up question to you. We've got about 3 minutes left. Is what work's been done to build the clinical workforce's capacity to engage in communications with affected communities, particularly gay and bisexual men, to ensure they feel comfortable and safe in clinical settings?
Well, to answer that question first, I think it's very much work in progress. I know that groups like yours and ASHM and ACID will be working very carefully to work with our broader colleagues, physicians and general practitioners around not just the technical details of the transmission, the presentation and treatment of this virus, but how we need to frame it carefully, and because at the moment it's largely gay and bisexual men in whom we'll be seeing it. But soon enough, there will be women who will be partners of bisexual men, and then children in their household, or children in the household of gay and bisexual men. So that's work in progress. And I don't know the extent of it at a national level, but I know there's a lot of discussion. I think that we need to remember that we do know a lot about this virus, in the sense that we can diagnose it, we can treat it, there's already a vaccine. Just like COVID, we quickly learned to characterize the virus and develop a vaccine. So it's about the virus, unlike HIV, which for many years we didn't know a lot about it. So we couldn't, if you like, vilify the virus. We instead vilified the people who got it. So that's the challenge here, is to say, we know a lot about this virus. It looks like close intimacy is a really big risk factor, and we're noticing that in men who have sex with men. But we strongly anticipate that this will happen in other populations, with sexual intimacy. So you make it about the virus, and it's an aside at the moment that it's in gay and bisexual men. But then groups like yours behove to educate gay and bisexual men about it, to protect themselves.
Thank you. I think they're nice words to finish with. I might introduce our CEO, Adjunct Professor Darryl O'Donnell, just to make some closing words before we finish up by 11.
Heath, thank you. Just a couple of observations from me. One is, we do have a situation. So we've got more than 1,000 cases in an outbreak, an unprecedented outbreak in the Northern Hemisphere, and we're seeing those cases imported into Australia. I think at this stage, we are needing to be on our toes, get really prepared, but this is a problem, and it's going to be a problem. So I think the moment when we hoped this would flash and disappear very quickly is starting to pass. Of course, we want this over as fast as it has arrived, but I think at this stage, our best assessment is we've got something that's going to need to be managed, and it will come here to Australia with additional cases. So part of the message is, for us as communities, we need to be ready, we need to be informed, and today is very much about that. The second thing is, I just want to make the observation that a lot of us working in clinical roles or in community roles, we're exhausted, we're over it. We've been through 40 years of this with HIV. We've just been through an incredible couple of years with COVID, and that continues. And now we've got monkeypox on top of it. As professionals, we actually have a duty as leaders to be following the evidence and thinking about what it requires of us. And I just want to caution all of us to be very, very careful of the sort of the instinct, our desire to wish this away. We certainly shouldn't over-escalate, but we do have a reality in front of us. It's really important to be ready for that, and we be able to lead our communities through that as professionals. We're working at AFAO with the councils and our other stakeholders on a daily basis. ACON has done, and thank you, Matt, for joining us. ACON's done an outstanding thing in terms of making available all of its messaging to other organisations, to other councils around Australia, in the hope of keeping our messaging consistent and backing in all of our organisations to make sure that we're getting the right messages out at the right time to communities. We are also working really closely with the department and with the Commonwealth, so there's a lot of movement behind the scenes to be ready, whether that's in the laboratory space, whether it's in the work of ATAGI, whether it's in the public health response through the Communicable Diseases Network, or through the work of the National Incident Room, which has been activated for monkeypox. So there's a lot of behind the scenes work, and while we have few cases in Australia, that's really important as we get ready. We will reactivate the COVID-19 list share that we used in order to share information at a community level during the early phases of COVID. We're keeping in touch. Understanding what was going on was really important. So if you're already on that list share, that's great. If you're not on that list share or you don't know what I'm talking about, please reach out to us at AFAO, and we're really happy to add you to that. We won't be spamming you, but it's a great way to keep informed, but also to share information that might be available. So thank you for joining. Really, really happy to have such strong attendance. Alan, so great to have your wisdom. Really appreciate you making the time today. It's been invaluable as we try to learn more about this. Edwina, as always, thank you for being part of our response and for stepping with us as we try and make sense of this as well. And Matt, thank you to you for your leadership on messaging and getting our communities ready for what might come. Thank you, everyone.
Thank you.